Hi, everyone. Welcome to this session focused on liver imaging. My name is Matt Morgan. I'm a radiologist at the University of Pennsylvania, and I am your host for this session. First up, we have a lecture by Ed Godfrey from Cambridge in the UK about diffuse liver disease. Then we have another radiologist from Cambridge, one of Ed's colleagues, Katie Hickman, and she's going to be talking about imaging and therapy of liver metastases. Then Ed Katie can join me for a panel discussion where we explore the current state of liver MR and where the field is heading. Finally, we're going to have a talk by Michael Nell reviewing liver segmental anatomy. As always, we are in the chat, so drop us any questions or comments you may have in there, and we'll try to address them. Let's get started with Ed Godfrey and diffuse liver disease.
Diffuse liver disease. Why is it important and what can you do about it as a radiologist? During this talk, I'll also discuss why nature loves a hexagon. This is an image of Giant's Causeway in Northern Ireland showing some of the 40,000 interlocking basalt columns. So what will we learn in this lecture? Well, I want at the end of it for you to understand the appearance of diffuse liver disease on conventional imaging, so ultrasound, CT and MR. I want you to understand the techniques we use with imaging, which are gold standard for detecting diffuse liver disease. And I want you to be able to produce actionable reports for your conventional imaging tests when you pick up diffuse liver disease. So the liver. The liver is the largest gland in the body with both endocrine and exocrine functions, and unusually it has a dual blood supply, as you all know. The liver develops in the ventral mesogastrium and due to foregut rotation migrates to the right upper quadrant. It has a number of important roles within physiology, but these include filtering the blood from the portomesenteric venous system. It metabolizes bilirubin to form bile. It is involved in protein production and particularly well known for producing albumin and clotting factors. And it's also an important carbohydrate store for glucose homeostasis. The liver parenchyma is made up of multiple polygonal hepatic lobules, typically with 6 portal triads arranged in a hexagon shape around a central vein. Now, it's important to admit here that the shapes in human livers are not always perfect hexagons, but that's often how they're shown diagrammatically, and it's a reasonable approximation of real life. So each hepatic lobule has a central vein, which drains to tributaries of the hepatic veins, and from there to the inferior vena cava and the heart. And surrounding each central vein, there are 6 portal triads. Each portal triad is made up of a branch of the hepatic artery and portal vein, as well as a bile duct tributary. The hexagonal arrangement minimizes the distance blood has to travel from the portal vein to the central vein. And as we've said, there's a dual blood supply with approximately 3/4 of the blood coming from the portal vein system and 1/4 from the hepatic arterial system. In portal hypertension, the flow of blood is impeded, and this causes reduced flow from the portal vein branches in particular, and in severe cases, the direction of flow can even reverse. The higher pressure arterial blood is not affected in the same way and can actually increase to make up for the reduced portal inflow, resulting in the arterialization of the liver that we can see on imaging. Bilirubin, as we've said, is metabolized in the liver to form bile by the hepatocytes. And once it's formed, the bile passes to the peripheral bile ducts and from there to the larger ducts of the biliary tree and eventually the gut. In diffuse liver disease, when it's advanced, there can be reduced bile production due to hepatocyte damage, as well as reduced production. There is a reduction in flow to the bile ducts by scarring. And this combination results in a mixed conjugated and unconjugated hyperbilirubinemia, what a mouthful, in advanced diffuse liver disease. So the jaundice you see as a cause of caused by diffuse liver disease is a mixed picture. The final problem that we see that I'm going to mention in diffuse liver disease is the triggering of malignancy by chronic inflammation in the liver. So malignancy is an important facet of the disease that we see in diffuse liver disease. So these are the most important complications that we need to think about, but there are many other complications of chronic liver disease. But the ones that we see most commonly as radiologists are patients with complications of portal hypertension, particularly bleeding from esophageal varices, which is the commonest cause of death in patients with diffuse liver disease. They may also develop ascites, and then they also commonly may develop jaundice or malignancy as well. There are a very large number of different sorts of diffuse liver disease, and I've listed some of them here. So metabolic dysfunction associated liver disease, alcohol-related liver disease, viral hepatitis, and various other conditions. But they tend to end in the same way, certainly the vast majority of these, in that they cause cirrhosis and portal hypertension. There are a few exceptions to this standard pathway. So, for example, patients with portosinusoidal vascular disease, also known as non-cirrhotic portal hypertension, will typically get the complications of portal hypertension, as you'd expect, like variceal hemorrhage or ascites, but they typically don't develop jaundice until much later in the condition, and that's because the disease predominantly affects the blood vessels rather than the liver parenchyma. Another exception to the general rule is chronic hepatitis, where even before these patients develop cirrhosis, they become a significantly increased risk of developing hepatic malignancy due to the chronic inflammation caused by viral infection. There are a number of new-ish terms that I think it's important to be familiar with when we're discussing these concepts, and some of them stem from this large consensus meeting, Bovino 7. They've just actually finished having Bovino 8, but the findings have not been written up yet. So you can eagerly anticipate the new guidance that we're going to receive from Bovino 8, but in the meantime, here is Bovino 7. Probably the biggest change is that we are moving away from using the term cirrhosis and towards this term cackled or compensated advanced chronic liver disease. And they do mean more or less the same thing, but the distinction is that cirrhosis is a histologically determined finding. So really, to call someone's say someone has cirrhosis, you need a liver biopsy. Now, we don't always resort to that, and sometimes we make the diagnosis using imaging. But technically, if you say someone has cirrhosis, really you're talking about a histological diagnosis. So because so much of the time we are now not using histology as our diagnostic test, we are using elastography, the consensus is that we should be using this alternative term to show that the diagnosis has been reached using non-invasive tests. So CACLD stands for compensated advanced chronic liver disease, and it's a bit of a mouthful, but once you start using it, you'll get used to it. You can see that on this slide, there's already some out-of-date terminology, though, because in the bottom right-hand corner, it mentions non-obese NASH, which has already become MASH since Bovino 7 was published. And I'm going to just talk to you a little bit about the changes in nomenclature for steatotic liver disease. So this used to be called NAFLD, but is now known as MASLD, which is metabolic dysfunction associated steatotic liver disease. That's one of the commonest causes of steatotic liver disease. One of the other common causes would be alcohol-related liver disease, and you can get both in the same patient, which is then called metabolic dysfunction and alcohol-related liver disease, or METALD, which is the condition listed in the middle. So you'll begin to hear these terms with increasing frequency. For the purposes of this talk, I'm going to concentrate on MASLD because it's the commonest liver disease by far in the population, and it's something that we will all see on a daily basis on our reporting lists. And I'm going to go through the different phases of the disease, and obviously those at the bottom of the pyramid are much more common and less serious, and as you progress through the different phases, you become more likely to die from your liver disease, but fortunately there are fewer patients affected in such a severe way. So let's start with steatosis. So for each level, I'm going to discuss what you can do about it as a patient, how you should report those findings on a scan, and then we'll go through the various imaging features that might suggest a particular phase of liver disease, and then finally the gold standard test. So for steatosis, there are things we can do for our patients with this, the most important one is to recommend lifestyle modifications. So these are things that we should all be doing more of, but things like moving more, eating a healthy, balanced, ideally Mediterranean-style diet. And also, there's the option now of weight loss drugs like semaglutide for patients who find lifestyle modification unhelpful. Now, obviously, weight loss drugs would only be appropriate in patients with obesity, but many patients with steatosis will be obese, and obesity is incredibly common. If you find steatosis on imaging, I think a helpful way of describing it in your report, or a helpful recommendation that you can make, is to say that it's present, so hepatic steatosis, and then recommend further tests to make sure that the patient doesn't have liver fibrosis, or if they do, then they can be directed to the appropriate services. So the best way to do this for steatotic liver disease, and particularly for MASLD, is to use a simple blood panel, which is the FIB4 test. It's nice and cheap, widely available, and is able to screen out a large number of patients that won't have any significant fibrosis. But if the FIB4 is raised, that doesn't mean they do have fibrosis. They then need to go on to a more specific test, and that would be, by and large, a fibroscan, or the generic term for that's a vibration-controlled transient elastography, and we'll talk about elastography later. What sort of things might you see on imaging to suggest that the patient has steatosis? We'll talk about this shortly, but the key things on ultrasound are increased echogenicity and beam attenuation. And you can measure these using controlled attenuation parameter ultrasound. And on CT, it will be a reduced liver attenuation, particularly on an unenhanced CT examination, where you can then be very accurate in your assessment of steatosis. But also, if you see any spared areas around, for example, the gallbladder fossa or falciform ligament, then you can also make an accurate diagnosis of steatosis on CT. And the gold standard, which we will cover later, is proton density fat fraction MRI. So here are some images of patients with liver steatosis, and these have previously been split into mild, moderate, and severe on ultrasound. But I think this is a very unhelpful concept, because these degrees of severity do not correlate in any way with the histological descriptions of mild, moderate, and severe, and therefore I think we're better off abandoning them as radiologists. What we should do on ultrasound is just say if there is steatosis present or absent. Okay, so even when it's subtle, I think it's reasonable to call it, and then there are other tests that the patient can undergo to see if there is significant liver disease or not. So in the left-hand panel, you can see there is relatively more subtle steatosis, but the echogenicity of the liver is increased compared to the renal cortex. In the middle panel, the echogenicity has increased to the extent that you are unable to make out the echogenic capsule around portal vein branches. And then finally, in the most apparent steatosis, the diaphragm is no longer visible due to beam attenuation. But as I say, I think that if you see any of these features, just report the presence of steatosis, but don't try and grade it as mild, moderate, or severe, because the ultrasound grading does not correlate with the histological grading. This is an image from a controlled attenuation parameter measurement in the liver, which will give a numerical measurement of the degree of hepatic steatosis, and this is going to become more widely used, but is not currently accurate enough to replace the gold standard, which I've said is MRI PDFF. We've said that CT is pretty good, and that's correct. The magic number you need to remember is 40 Hounsfield units. And if the attenuation of the liver is less than 40 Hounsfield units on an unenhanced CT, then you can be 100% certain that the patient has at least moderate hepatic steatosis, and that's moderate by histological criteria. So it's a very specific finding if you see that. You can see these areas arrowed as well, which are areas of focal sparing, both around the gallbladder fossa and posteriorly in the left lateral section. And again, if you see focal fat sparing anywhere in the liver on either a contrast enhanced or an unenhanced examination, then you can be 100% certain that the patient has at least moderate hepatic steatosis by histological terms. So it's a very useful thing to use on CT. We'll all be familiar with in and out of phase T1 weighted imaging, or 2-point Dixon imaging, where in and out of phase images, which you can see on the bottom left and bottom right panels, are then used to create a water only top left and fat only top right image. And we can use these images to get a rough feel for whether the patient has hepatic steatosis. There is a problem with this in that the presence of fat can be confounded by the presence of iron. So this is a very rough and ready way of seeing if there's fat in the liver, and is certainly not foolproof. What you need to do is use the gold standard imaging technique, which is proton density fat fraction imaging, which is a multi-point Dixon technique. Here's an example of that in a patient with severe hepatic steatosis. So if the liver is normal, it will be as dark as the spleen in this image with no measurable fat. And this explains why you need to have more than 2 points. So this is the signal you get using a proton density fat fraction sequence, and typically there'll be 6 time points measured. And you can see the signal changing here. So I'll just go back to the beginning of this slide. The waviness of the line is determined by how much fat is in the liver. So this is with increasing liver fat, back to normal now. And then the rate at which the signal decays over time, which is increasing now, is determined by the level of iron. So you can see you need a number of time points to be able to map out this curve, rather than just 2, where you could mistake presence of, the iron could mask the presence of fat, or vice versa. So just to summarize then, in steatosis, there are things we can do like lifestyle modification and drugs like semaglutide. It's important to suggest, if you see it, that the patient goes on to have risk stratification using a blood panel and typically FibroScan elastography. We've talked through the different features on imaging and mentioned the gold standard test. So I'm going to move up the next rung now, which is to steatohepatitis. So steatohepatitis is, again, something that we can treat as doctors. And in addition to those treatments that we mentioned for steatosis, which are lifestyle changes and weight loss drugs, there are now targeted drugs that we can give patients who we know have MASLD-related steatohepatitis. So resmetirom is the first specific agent for MASH, which reduces hepatic fat and inflammation. But there are several other drug classes in the pipeline. So you'll see more of this in clinical practice in the near future. Now, the next thing we should mention is how you should report this. Unfortunately, you never need to know how to report steatohepatitis because it is not detectable with pretty much any imaging. So that's conventional imaging, ultrasound, CT, MR, or even specialized MR techniques really don't show steatohepatitis very well. There is some suggestion that you might be able to use a combination of MR elastography and corrected T1, but I think that's really a research tool. So to all intents and purposes, if you need to know whether the patient has inflammation in the liver, and this is true for MASLD, but other conditions like autoimmune hepatitis, the only way you can find that out is with a liver biopsy. So liver biopsy still has its place. Where you're looking for inflammation, there's no other way of doing it. And the inflammatory grade is actually quite important in some conditions. The higher the inflammatory grade, or the more inflamed the liver is, the more likely the patient will progress rapidly through different stages of fibrosis. So if a patient has a lot of inflammation in their liver, they need more active treatment. So a quick discussion of liver biopsy. Why is it good? Why is it bad? Well, as we said, it's the only way to find out if there's inflammation in the liver. But it has some major drawbacks. One of them is sampling error. So you're sampling a very small area of the liver, and some of these conditions affect the liver quite heterogeneously. So you can end up with an erroneously good or bad result depending on where you take the biopsy from, and you wouldn't know that. In addition, there's variability in how the biopsy is interpreted, and there are very important complications that can arise from this, up to and including death from a diagnostic procedure, which is not a common scenario for us in the modern age. And here's an advanced Doppler image of a patient who I'd done a liver biopsy on, and you can see that there's a vascularized linear tract extending up to the liver capsule here, and the patient was having a bleed at the time. I'm pleased to say that he survived without needing any further intervention. So that's steatohepatitis, and we've said that, again, it's a treatable condition and that there are an increasing number of targeted drugs that we can use for patients with this condition, but that it's not something we can see on imaging. It needs a liver biopsy to diagnose it. Moving up to the next stage, after you've had some inflammation, you will begin to develop fibrosis. Now, fibrosis can also be treated with lifestyle interventions, with weight loss drugs, and with maybe targeted therapies such as resmetirom. But if you have other indications for weight loss surgery, it's very likely that weight loss surgery will benefit the degree of liver fibrosis. So it's another consideration to feed into decision making around weight loss surgery if that's being considered. When you're reporting fibrosis, it will pretty much always be when you're using a form of elastography. So typically I would recommend to report the stiffness in kilopascals and to give an indication as to the level of stiffness and what likely fibrotic range that would indicate. So is the liver normal? Is there some fibrosis, or does the patient have cirrhosis or even portal hypertension? So all of these things can be determined from an elastography test. But generally, we would accept that you can't see fibrosis with conventional imaging of any sort. So ultrasound, CT, and standard MR, you're not going to be able to see it. The different sorts of elastography we'll discuss shortly, but they're either ultrasound or MR-based techniques. And the gold standard, particularly for fibrosis, because it's better at separating out the different stages of fibrosis in the liver. And typically we divide fibrosis into 4 stages. So normal is 0, mild, moderate, and severe fibrosis are stage 1, 2, and 3. And then stage 4 would correspond to cirrhosis, which is the end stage and different to the others in that it's generally thought to be irreversible, whereas stage 1 to 3 fibrosis can be reversed if you remove the underlying cause. Let's talk about elastography. So there are a number of different types of elastography, and the first dichotomy is between strain elastography and shear wave elastography. So a quick mention about strain elastography. It's largely of historical interest. We don't use it much in clinical practice, but it works by looking at the longitudinal displacement of pixels in an ultrasound image, like we have here. In a stiff area, those pixels will remain a fixed distance apart, whereas in soft areas, they'll move closer and further away from each other. And so you can get a subjective stiffness map, like in this image here of a cholangiocarcinoma in the liver. But it doesn't give you numerical outputs, and so therefore is not useful in measuring the stiffness of the liver when assessing diffuse liver disease. So we can forget about strain elastography. Everything else is a form of shear wave elastography. And both the ultrasound-based techniques are transient forms of shear wave elastography. And what that means is that they work by a single impulse to the liver to cause a vibration, and then imaging of that vibration or shear wave as it disperses from where it was administered. And the faster the shear wave moves through the liver, the stiffer the liver, and therefore likely to be the more fibrosis present. So of the 2 different techniques, there's mechanical transient elastography, which is also known as FibroScan by the manufacturers, and in the literature often is described as vibration-controlled transient elastography, or VCTE. The other sort of transient elastography is acoustic radiation force impulse imaging, which is the one that we use more often as radiologists and is typically an upgrade to high-end ultrasound machines. And instead of using a mechanical piston that taps on the outside of the patient, like in FibroScan, it uses a high-energy pulse of ultrasound energy to cause a vibration in the liver. And then the dispersion of the wave as it travels out from that point is imaged using ultrasound. So let's have a little look about that then. So on the left of this image is an output from a FibroScan machine. So it's not an imaging technique, even though it uses ultrasound, but it gives you numerical outputs for the liver stiffness, and also in modern devices will give a controlled attenuation parameter. So you can assess liver steatosis with it as well. On the right of the screen is the output from an ARFI acquisition, and the rainbow colored lines are a qualitative map showing that this is a relatively good quality acquisition because they're parallel and vertical, and you can measure the stiffness in this way. I've got some tips for you if you're going to do ARFI. I think it's a really useful skill to pick up as a radiologist, and it's not very difficult to learn. The main things are that you need to fast your patients for 4 hours beforehand, because we know that after a meal, the stiffness of the liver can increase due to increased portal blood flow. It's important that you only measure stiffness in the right lobe, because the contraction of the heart can distort the liver in the left lobe and change the stiffness during the cardiac cycle. So you may get unreliable measurements. You should do it at relaxed end expiration, and that's because if you do a Valsalva, it will increase the liver stiffness. And We know that patient position can also affect the liver stiffness, so your patient should be horizontal or slightly sat up, but not vertical. You should measure 1 to 2 centimeters deep to the capsule, and that's because there is an artifactual increase in stiffness just deep to the capsule. And you should take several measurements and take an average. The key numbers to report are the median and the variance divided by the median. And you can get away with only 5 measurements if you're using a 2-dimensional shear wave technique like the one shown here, where you have a region of interest, or if it's a point shear wave elastography technique where just a small area is measured, then you need to take 10 measurements and calculate those numbers. And it's really useful using a template report so that you include all the relevant details, including the meaning of a particular liver stiffness that you're describing for the patient. And remember, with both FibroScan and RFE and MR elastography, you can look at the stiffness of the spleen as an indicator for portal hypertension, as well as measuring the liver stiffness. And below 25 is pretty normal for the spleen, and above 40 is very much suggesting portal hypertension. So we've talked about the ultrasound-based techniques, which are both transient elastography. And then finally, the last sort of elastography is harmonic shear wave elastography, and that the only type of harmonic elastography is MR. So the difference is in harmonic elastography that rather than just a single impulse causing a vibration in the liver is subjected to regular impulses to cause a standing wave to be set up. So the best way to imagine that is if you have a vibrating coffee machine on your draining board at home and the sink is full of water, as it vibrates, it might set up a standing wave of ripples in the water that appear to be not moving. And with this technique, we can image the passage of the shear wave through the liver. And just like with ultrasound, the faster the wave moves, the stiffer the liver and the likely higher the fibrotic stage. And these are some beautiful colored images that you can produce with this technique, which are of no use clinically whatsoever, but we use them for presentations. The outputs that we actually use clinically are fairly dry black and white images, but the color ones are nice to have too. So how does MR elastography work? Well, you need an active driver, which is the box at the bottom left-hand corner here, and a passive driver, which is the ping pong bat shape attached to a garden hose. And those two are joined together. And the active driver is a bit like a Hoover in reverse and sends out puffs of air along the garden hose to the ping pong bat. And the ping pong bat shaped area has a membrane stretched over it, which is put in contact with the patient, and that vibrates at a particular frequency, usually 60 hertz, and that transmits vibrations through the patient into the liver. And then we use special MR sequences to image that standing wave once it's been set up. And in a stiff liver, you can see the peaks and troughs are relatively separated, versus in a soft liver where they're much closer together. So this is the basis of the technique. Now, there are confounders for all sorts of elastography techniques, and that's because a stiff liver doesn't necessarily mean a fibrotic liver. There are other things that increase the liver stiffness. The commonest of these is venous congestion. So in patients with heart failure, then the flow of blood out through the hepatic veins and into the IVC will be impaired. You might see a dilated IVC or hepatic veins, and as in this case, you can actually see tricuspid regurgitation on the B-mode images. So look out for imaging features suggestive of right heart failure, because they may be giving you a clue that the increased stiffness in the liver is not due to fibrosis. It may be due to venous congestion. We do see increased stiffness also in biliary obstruction or in someone who's just had a Big Mac. And inflammation will, to a certain extent, increase the stiffness of the liver, but it's quite variable and unpredictable. So, as we said, inflammation is best detected by a liver biopsy. Interestingly, fat doesn't change the stiffness of the liver at all. So you can forget fat as a confounder. The only situation where fat does increase the stiffness of the liver is at room temperature, which is probably a bit late for your patient if they're already at room temperature. We said Valsalva maneuvers and also tumor infiltration can also increase the stiffness of the liver. So just have a list in your head of just to run through, but the main ones are venous congestion and biliary obstruction, which can give you an erroneously high stiffness. And These techniques are all complementary, so it's nice having a range of different options. We know that because FibroScan works using a mechanical impulse, so a metal cylinder tapping on the outside of the patient, in patients with ascites, that can dampen the mechanical signal and prevent it from getting to the liver. So FibroScan will not typically work in patients with ascites like this one, but the ascites, if anything, is a help if you're using RFI, shear wave elastography. And so we were able to get completely diagnostic measurements in this patient despite the presence of ascites with RFI. And the patient, interestingly, had a relatively normal liver stiffness. This is a patient with non-cirrhotic portal hypertension. So often these patients will have a liver stiffness in the fibrotic range, but not in the cirrhotic range, not so severe. RFI and FibroScan both tend to fail in patients with a lot of liver fat, and that's because the fat will absorb the ultrasound waves to the extent that you're unable to measure the shear wave as it passes through the liver. So these patients do really well with MR elastography, and you can measure the stiffness. And this is what a standard elastography image looks like. I told you it's a lot more boring black and white and grey image, but gives you very useful information. And this patient has a normal liver stiffness, so no fibrosis whatsoever, but they have a very increased signal on their proton density fat fraction map. And that implies that they've got severe hepatic steatosis, which tells you exactly why the ultrasound-based techniques didn't work. Even MRI will fail in some patients, either because they're claustrophobic or because they have so much iron in their liver due to either transfusional overload or hemochromatosis, where you will not be able to get enough MR signal back from the liver due to the iron. And so you can go back to an ultrasound-based technique in these patients. And here's an example where in someone with hemochromatosis, we were able to get a diagnostic liver stiffness using RFI rather than MR elastography. So that's fibrosis. The mainstay of fibrosis imaging is elastography of the various different types. And as I've said, the most important thing for you to do when you're reporting is to use a template report, which includes all the important details. Moving up to the penultimate rung now, these are patients which we used to call patients with cirrhosis, but now we should be generally using the term CACLD or CACLD, which stands for compensated advanced chronic liver disease. So cirrhosis is reserved for patients who've got a histological diagnosis. By and large, we're making the diagnosis in patients using elastography these days. And these patients can unlock a variety of different treatments when they reach this stage. The commonest one would be HCC surveillance. So that would be, in most places, a 6-monthly liver ultrasound and a 6-monthly alpha-fetoprotein measurement. Not all patients with CACLD will need a transplant, but some of them will, and generally transplant begins to be considered at this stage depending on a variety of different factors that feed into the MELD score. If you see CACLD and it's not known, then I think it's helpful to report that in this way. So you can say, particularly if a patient's got a nodular liver contour, you could report it saying features suggestive of CACLD or cirrhosis, hepatology referral is recommended. And then the patient can either undergo further investigation if the hepatologists feel it's required, or they can go into an HCC surveillance program. If you're not completely sure if a patient has CACLD on the basis of imaging, then it's completely fine to equivocate. There's a very comfortable place on the fence for you in these patients, which is to say there's possibly some chronic liver disease and recommend a FibroScan, because that's a very cheap test that will definitely unravel whether the patient has CACLD or not in the vast majority. And the best thing about a FibroScan is that it's not done by the radiology department. So you're not even creating more work for your colleagues. Wonderful. We're going to discuss the ultrasound, CT, and MR features of CACLD/cirrhosis in a minute, but any sort of elastography is pretty much the gold standard for detecting this. MRE is marginally better than the other techniques, but actually there's not so much in it once you get to the point of having CACLD, and that's because there's a big jump in liver stiffness at this point, whereas the increase in stiffness at earlier stages of fibrosis, so that stages 1 to 3, is much less. So any sort of elastography is the gold standard for diagnosing CACLD. So let's talk about the imaging features of CACLD/cirrhosis. Well, the one that you'll be most familiar with is a nodular liver contour, and that is the most specific sign as well. It's pretty much almost always going to be due to cirrhosis. There are rare diseases that will give you a nodular liver that aren't cirrhosis, such as nodular regenerative hyperplasia, NRH, which is a condition that would sit under the portosinusoidal vascular disease umbrella. So if you overcall it and the patient ends up under hepatology, they've gone to the right place anyway, although the hepatologists will have to will hope that they make the correct diagnosis. Other features you can see on imaging are hypertrophy of parts of the liver, particularly the caudate lobe and left lateral section. And you see atrophy in other parts of the liver, like the left medial section and the right anterior section. And that typically causes an increase in the size of the gallbladder fossa. You can also see a right posterior hepatic notch, like in this case, and that's generally quite a good predictor. So if that's present, even if there are no other features to suggest liver disease, I would suggest a FibroScan for those patients. On MRI, there's an additional feature you might see, which is linear T2 hyperintensities, which this is a good example of that. And this is fibrotic tissue around the cirrhotic nodules. Usually fibrotic tissue is low signal on all sequences elsewhere in the body, but unusually in the liver, it's hyper intense on T2 weighted imaging, and that's due to edema. But it's an unusual manifestation of fibrotic tissue. In the rest of the body, you would expect it to be dark. So here is a CT, and I think if you assess the liver in this patient, it's got a smooth contour. I don't think there's much in terms of the morphology that would make you think that this patient is cirrhotic, but they do have a confirmed diagnosis of actually CACLD, which we were able to do with MR elastography. So this is an important case in that it reminds us that with conventional imaging, we're probably only 70 to 80% sensitive for cirrhosis/CACLD. So conventional imaging is not as sensitive as we would like it to be for even quite advanced diffuse liver disease. So that's CACLD, or what used to be called cirrhosis, less so these days. And the key thing we've said is that the patient should be referred to hepatology if you think they've definitely got it, or you should suggest a FibroScan if you're not sure. And there are certainly still treatment options for patients even with this severe disease. So it's important that they're under the right team. Moving on to the final and most severe phase of liver disease, which is portal hypertension. These patients do need quite intensive surveillance, both for HCC, so they'll continue having that like the patients who just had cirrhosis, but they also need now surveillance for the complications of portal hypertension, and in particular, esophageal varices. And if esophageal varices are detected, then they'll be treated typically with band ligation to reduce the risk of variceal hemorrhage, which can be very commonly life-threatening. There are other maneuvers that we can do to reduce the risk of bleeding in these patients. So a common one that radiologists would be involved in would be a TIPS shunt, but there are other shunts as well that can be created for these patients, either by the surgeons or the radiologists. If you see features that suggest portal hypertension, then I think it's important to signpost the patient towards the hepatologists if they're not already known to them. And we'll talk about the imaging features that might lead you to suggest that shortly, but there are features on ultrasound, CT and MR. The gold standard for measuring portal hypertension is hepatic venous pressure gradient. So that's an interventional radiology procedure where a catheter is passed down from the jugular vein in the neck through the heart and into the hepatic veins of the liver. And then pressure measurements are made when the catheter is either wedged or not wedged. And then the pressure gradient across the liver can be inferred by those measurements. So that's traditionally how we assess the severity of portal hypertension and determine if it is present or absent. More recently, there's been interest in using EUS portal vein pressure gradients, which is a similar technique which can be done through EUS, and probably they're complementary techniques. So what sort of imaging features are we on the lookout for? Well, certainly splenomegaly, as this patient has in spades, is a sign that the patient may have portal hypertension. But there are plenty of other causes for splenomegaly, so it's not a straightforward sign to interpret. But in the context of a patient who looks like they have CACLD and a big spleen, then the likelihood is that they have cirrhosis and portal hypertension. The other things that we can look for on ultrasound and other sorts of imaging are shunt vessels. So these would include a dilated paraumbilical vein, And please note that it's a dilated paraumbilical vein. If you call it a recanalized umbilical vein, you're wrong on both counts. It's a dilated paraumbilical vein. You might also see shunts in the splenorenal region, and you can see periesophageal and perigastric shunts or varices. In terms of the splenic size, I tend to use 14 centimeters as my cutoff. Some people might use slightly lower numbers, but I think generally you're aiming for specificity rather than sensitivity with this. So if you miss a very small amount of mild splenomegaly, it's probably not a huge problem. If you see a portal vein greater than 14 millimeters, that's also suggestive of portal hypertension. And of course, if you see ascites, that's again suggestive, but there are other causes for ascites, just like there are for splenomegaly. With Doppler ultrasound, there are a number of features you can look for. First of all, we mentioned arterialization, which this patient has, which is where the branches of the hepatic artery are more prominent than you would normally expect them to be. It's quite a subjective call, but can be quite helpful to trigger you to look for other features of cirrhosis and portal hypertension. You can see changes in the portal vein flow as well on Doppler, either with a reduced flow, and anything less than 12 centimeters is reduced, or you can see reverse portal vein flow, like in this case. So normally the portal vein would light up in red, unless you have your machine settings the wrong way around. A blue portal vein indicates reverse portal vein flow away from the liver. You can also occasionally see balanced portal vein flow, where it will move to and fro during the cardiac cycle. There's an important tip here, which is in patients with MASLD, they often have a very attenuating liver, and it can be difficult to demonstrate Doppler flow in the portal vein, particularly in the deeper parts of the liver. And so if you are struggling, remember that you can reduce the color frequency in the same way as the B mode frequency can be reduced, and that will improve your depth of penetration. So we've talked about the different imaging features of portal hypertension. We've talked about what can be done for these patients, and there are definite treatments that they will benefit from. And we've talked about the importance of reporting them so that they can be steered towards hepatology who can coordinate what needs to be done. So that's the run through of the different phases of severity of MASLD. And now I'm going to talk a little bit about hexagons. So hexagons in nature, they do crop up, although they are relatively uncommon. And on the left, we have hexagonal columns of basalt, and they come about because this is the most efficient way to release stored elastic strain energy as the basalt slowly cools. And it's to do with the angle that the cracks make when they meet, which is roughly 120 degrees. Honeycombs are hexagonal, probably for different reasons, though. It's most likely because it's the most efficient way of storing the most amount of honey with the minimum amount of wax, but also maybe just due to the way that circular cells pack in a hexagonal way more efficiently. So it may be that the bees are actually making circular cells, but then when they all squish together and the wax is slightly soft, they end up with this hexagonal appearance. And then finally in the liver, why do we see hexagons in the liver? Well, the reason for that is because it's the most efficient way to interlace two different networks of blood vessels. So the central vein and the portal triads arranged around it mean that the distance that the blood has to go from one to the other is kept to an absolute minimum. Just to refresh our memories of the gold standard ways of diagnosing the different phases, we said that for steatosis, MR proton density fat fraction is the best technique, and that's a multi-point Dixon technique. It doesn't need extra hardware for your machine, but is an additional sequence that you'll need to purchase from the vendor most likely. We've said that steatohepatitis, or inflammation of the liver, can only be diagnosed on biopsy. We've said that fibrosis is often going to manifest as a more subtle increase in stiffness in the liver. And so MR elastography is the gold standard, being the most sensitive way of detecting that. And that does require additional hardware, although not a huge amount, and is a very useful technique. I'd really recommend if you're doing a large volume of hepatology at your center, do consider setting this up as a service, because it will save you from having to do lots of liver biopsies and save patients from having bleeds and even more serious complications from liver biopsies. If you want to diagnose patients with compensated advanced chronic liver disease, or cackled, which used to be more commonly called cirrhosis, then you can use any sort of elastography because the stiffness will be markedly increased. And then for portal hypertension, the gold standard is hepatic vein pressure gradient, or EUS, portal vein pressure gradient. But actually, by and large, we can identify patients with portal hypertension using a combination of conventional imaging looking for shunts and splenomegaly, and also using elastography again, because the liver stiffness and the spleen stiffness will both be markedly increased. Here are the sorts of things that we want to say for different features that we see. So starting at the bottom, steatosis. If you see that, it's important to recommend FIB4, which is a blood panel to stratify patients as to whether they need a fibroscan, and then fibroscan to rule in or out significant fibrosis. And in patients with significant fibrosis, they'll need to go to hepatology. We've said that fibrosis is occult to conventional imaging, so you'll only really be thinking about fibrosis when you are doing elastography, and to use a template report for elastography reports to make sure that you include all the important details. In patients who you think have cackled or cirrhosis, it's important to steer them towards hepatology. And if you're not sure, then do suggest a fibroscan. It's a cheap test that someone else does, so it's a really great test. And if you think that someone has portal hypertension, again, they need to go towards hepatology and go into the relevant screening programs. So I hope that we've covered the various learning objectives that we'd aim to cover, which are the appearance of diffuse liver disease on conventional ultrasound, CT and MR, using steatotic liver disease as an example. And then I hope that you're happy with the gold standard imaging techniques for diffuse liver disease, in particular MR elastography and proton density fat fraction. I also hope that you're able to produce actionable reports. And I'd like to thank my colleagues who helped me with this talk, particularly David Bowden and Mike Allison and Will Jelson. And if you want to get in touch with me, if you have any questions or comments, please let me know. There's my email address. Thank you very much.
Hello, my name's Katie Hickman. I'm a GI radiologist in Cambridge, and today I'm going to talk about liver metastases, how we can use imaging not only to characterize liver lesions, but also make sure we detect all of the lesions in the liver, and then move on to talking about current as well as emerging treatment options. This is a 37-year-old man who presents with a 6-month history of worsening left upper quadrant pain. The transverse and ascending colon are dilated upstream of an obstructing mass at the splenic flexure. The only other finding is a solitary 9 mm hypoattenuating lesion within the liver, measuring around 20 Hounsfield units. The patient has never been to hospital, so we have no prior imaging for comparison. So the question is this a liver metastasis, a hemangioma, or something else? To make sense of our patient's liver lesion, I'm going to work through the problem in a way I think it often unfolds in real practice. We'll start with indeterminate liver lesions, the common scenario where CT shows us something in the liver, but we cannot confidently say if it is benign or malignant. And just as importantly, does that uncertainty matter for this patient? Second, we'll talk about MRI for characterization purposes. Here the question is, what is the lesion? We'll look at how MRI helps us separate benign from malignant lesions and why the choice of contrast agent matters. Third, a mapping MRI. This is a different question. Once metastatic disease is confirmed, we are no longer just asking what is the lesion, we're asking how many lesions are there, where are they, and could they change the surgical plan. Then we'll take the imaging to the MDT, where the report becomes the surgeon and interventional radiologist map. Finally, we'll look at how imaging guides resection and ablation, as well as emerging treatment options such as histotripsy and transplantation. Returning to our patient and continuing with the question, is this indeterminate lesion benign or malignant? And since we'll be following this patient throughout the talk, I'll use this orange icon each time their images appear to clearly distinguish them from the comparison cases. Now, because the splenic flexure tumour was obstructing, he underwent emergency surgical resection, which confirmed a colonic adenocarcinoma. He then had a completion staging CT chest, which did not show pulmonary metastasis. So at this point, the only potential site of metastatic disease is the indeterminate sub-centimetre liver lesion. Before we decide what to do next, I want to show you 2 other patients with almost identical looking lesions. First is a 20-year-old having a CT for suspected appendicitis. They have no known malignancy, no hepatic risk factors, and normal background liver. Again, there is a 9 mm low attenuation lesion measuring around 20 Hounsfield units. In this context, this is almost certainly a tiny cyst or hemangioma, even though we cannot fully characterize it on this single portal phase CT. Now compare this with this 50-year-old patient with alcohol-related cirrhosis. Again, there are small hypoattenuating lesions, but the context is completely different. In the cirrhotic liver, we must think about primary liver malignancy, so HCC and cholangiocarcinoma. So benign and malignant lesions may look similar on a single portal phase CT, but the pretest probability is very different, depending on whether you have a low-risk patient or a high-risk patient. High risk defined as known or suspected malignancy, cirrhosis, as well as other hepatic risk factors. This is where the 2017 American College of Radiology incidental liver lesion guidance is so useful. It gives us a practical framework for incidental liver lesions based on risk profile. And crucially, it does not ask us to characterize every tiny liver lesion. You could consider adapting it to suit your local practice, as we have done, but for day-to-day CT reporting, the most useful take-home is this. In a low-risk patient with no known malignancy and no hepatic risk factors, an incidental liver lesion less than 1 centimetre generally needs no further workup and can be considered benign. That matters because phrases like too small to characterise or not fully characterise can unintentionally trigger ultrasound and MRI follow-up for lesions that do not need it. I prefer small benign hepatic hyperdensity less than 1 centimetre of no clinical concern. But of course this is not licensed to ignore odd-looking lesions. If a small lesion has concerning features such as ill-defined margins or a thick septation, then it shouldn't be dismissed, and instead I advise you to seek specialist advice. However, high-risk patients are different. Now the question becomes, could this lesion change management? And in our case, the answer is yes, because whilst historically most patients with liver metastasis were considered inoperable and managed palliatively, advances in surgery and interventional radiology mean patients are now candidates for liver-directed treatment potentially offering a cure when certain criteria are met. And so thinking about our case, if this liver lesion does turn out to be a metastasis, he's young with good performance status. He has colorectal cancer, the group where we have the strongest evidence for successful liver-directed outcomes. He has no extrahepatic disease, just a solitary liver lesion, and we're wondering if it's benign or malignant. Final technical resectability and future liver remnant assessment will be decided at MDT, but at this stage he clearly fits the profile of someone in whom further characterization could change the entire treatment pathway. Compare that with a patient with colorectal cancer who has extensive liver metastases throughout all segments, as well as extrahepatic disease. In that setting, treatment intent is more likely to be palliative systemic therapy, and characterizing every liver lesion with MRI is unlikely to change management. So in summary, use the ACR guidance to avoid over-investigating tiny low-risk incidental lesions, but in higher-risk patients pause and ask whether the finding will change management. So we have decided that this lesion needs further assessment. The next question is, what type of MRI should we perform to characterize the lesion? Broadly, there are two contrast options for liver MR. Most routine studies use an extracellular agent such as Gadavist, which behaves like CT contrast and is useful for characterizing lesions by their enhancement pattern. The other option is a hepatobiliary agent such as Primavist, which provides early arterial and portal dynamic phases similar to Gadavist, but after 3 minutes is taken up by functioning hepatocytes. So by the hepatobiliary phase, which is acquired around 20 minutes, normal liver parenchyma becomes bright, while lesions without functioning hepatocytes, such as metastases, remain dark. That makes Primavist particularly useful for detecting and mapping liver metastases. So in simple terms, extracellular agents are excellent for asking, what is this lesion? Whilst Primavist is great for asking, are there any more lesions? Now, centres will vary as to how they image liver metastases, but the key is knowing what each contrast agent is best at. This was a Gadavist study rather than a Primavist study because the hepatic veins progressively brighten, and crucially, there's no contrast within the bile ducts. Now, it's a bit unusual this case because at our study, at our centre, we would usually start with a Primavist study for suspected colorectal liver metastases and only reserve a Gadavist study for problem solving. But it's helpful to have a Gadavist study here because we can begin by talking about lesion characterization before moving on to detection and surgical mapping. So using the other sequences which are part of this study, at the site of the liver lesion, the T2 signal is so bright you could mistake it for a cyst. But look carefully at the periphery. There is a subtle halo of intermediate T2 signal, which marks the viable tumour rim. The bright centre is necrosis, and necrosis is common in colorectal liver metastasis even before treatment as the tumour outstrips its blood supply. We see this reflected on diffusion imaging. There is peripheral low ADC signal in the viable hypercellular tumour rim, whereas there's elevated ADC signal centrally where the cell membranes are broken down as the cells die. Now, when these hypovascular liver metastases are larger on CT, this becomes the classic target sign, as we can see in this companion case here. And on MRI, the same architecture is more conspicuous with a thick peripheral rim of viable tumour cells. And these peripheral viable cells show progressive enhancement, whilst the necrotic centre remains hypointense. Now, returning to our patient's smaller lesion, the rim is subtle and enhancement minimal, showing just how difficult it can be to characterise small liver metastases. Now moving on to a different type of liver metastasis, mucinous adenocarcinoma accounts for around 10 to 15% of colorectal cancers, and its liver metastases look different on MRI, with very high T2 signal, high DWI signal, and high ADC signal. So you can see how easily mucinous metastases might be mistaken for cysts or hemangiomata. So now let's look at a case which contains all three. Here in segment 8 we see a simple cyst, whereas down in the left medial section there is that mucinous metastasis, whilst over here in the left lateral section is a hemangioma. The distinguishing feature of mucinous metastases, therefore, is a continuous fibrotic peripheral rim, which demonstrates progressive enhancement through to the delayed phase. That continuous rim excludes a hemangioma, which we can see here in the same liver, showing nodular discontinuous peripheral enhancement with centropetal fill-in by the delayed phase. For our next case, you are reviewing a portal phase CT follow-up imaging for a patient with known breast cancer. These hepatic hyperdensities measure 5 Hounsfield units and have remained stable since the baseline CT 4 years ago, in keeping with simple cysts. No additional liver lesions are identified. However, when we review the CT from 3 months earlier, we can see multiple enhancing lesions throughout the liver that are not visible on today's study. To understand this, we need to look carefully at the scan technique. Although this is described as a portal phase CT, it is actually closer to a late arterial phase, with contrast still present in the aorta and the portal veins. By comparison, the hepatic veins have not yet fully opacified. Whereas the other follow-up studies were acquired in a true portal phase with contrast in both the portal and hepatic veins. So to clarify what's happening in the liver, a gadabist MRI is then performed. And as part of that gadabist MRI, we have a high-quality true arterial phase sequence. And here you can see innumerable arterial enhancing lesions, some of which show that peripheral rim of enhancement. So whilst colorectal metastases and metastases from many other cancers are hypovascular and so best seen on the portal venous phase, some tumours, including neuroendocrine, renal, melanoma, and occasionally breast cancer, produced hypervascular metastases, which are best seen in the arterial phase and may be missed on portal venous imaging alone. In this breast cancer case, the lesions enhance arterially but become isoattenuating on the portal phase, so single-phase imaging would have missed the metastases entirely. The key point is that imaging needs to match tumour biology. Portal venous phase CT is essential for colorectal cancer, while arterial phase imaging is critical for hypervascular primaries. Breast cancer lies in the grey area. Most breast cancer metastases are hypovascular. However, between 10 and 25% will be hypervascular, like this case. And so locally, we're discussing whether to add an arterial phase to the breast cancer CT protocol follow-up. Once we know that we're dealing with metastatic disease, the question changes entirely. It's no longer, what is this lesion? It becomes, are there any more? So why isn't gadabist MR sufficient to detect all of the metastasis? Let's look at what the sensitivity data tells us. So across the board, sensitivity improves as we move from CT to gadabist MR to primavist with DWI. But where this really matters is for subcentimeter lesions. On CT, for subcentimeter lesions, we pick up only around a half of small deposits. Gadavist MR still misses more than a third. With primavist HPB imaging, that detection rate climbs to around 80%, and adding in DWI on top gets us close to 90% of those subcentimeter deposits detected. And knowing about those small lesions and acting early is one factor that is leading to better outcomes for these patients. Let's look at an example. So on CT, you can see a prior non-anatomical resection site anteriorly within segment 5, but nothing more. On the MRI acquired within the same month, a lesion is visible restricting diffusion and appearing dark against the bright liver parenchyma on the hepatobiliary phase. So this is the same patient, same month. Now returning to our patient and their primavist study. Now, primavist, as we've said, behaves like other contrast agents during the early vascular phase, producing standard late arterial and portal phase images as we see here. But I want to draw your attention to a well-recognised phenomenon with this agent. In roughly 10 to 15% of injections, it triggers a transient sensation of breathlessness. This is a physiological response that causes the patient to break their breath hold, resulting in motion artifact that can render the arterial and portal phase sequences non-diagnostic, as you can see here. This matters if you're trying to characterise a lesion, because distinguishing a hemangioma from a metastasis, for example, will be almost impossible if we don't have the arterial and portal phases. And that's where you might want to repeat the study, this time using gadavist, because gadavist does not cause the same transient dyspnea, so you more reliably get clean dynamic phases. After the portal phase, from around 2 to 3 minutes and peaking at 10 to 20 minutes, contrast is taken up into hepatocytes, and so the liver parenchyma is very bright, and contrast can be seen within the bile ducts. This hepatobiliary phase is where Primavist really earns its place in metastases imaging. But a word of caution. It's not only metastases that go dark. All focal lesions lacking hepatocytes will be hyperintense, including cysts, as you can see here. So we can't rely on the HPB phase alone, we need all our sequences. This MR was performed 2 weeks after the Gadavis study, and now we can really see that peripheral rim of viable tumour cells at the site of the known metastasis. But up here in segment 7, there is a 5mm lesion that we do not see on the T2 sequence, like we did for those cysts. For example, another cyst down here in the left medial section. So we know the segment 7 lesion is not a cyst. Using our other sequences, we see that there is diffusion restriction at this site. The high DWI signal cannot be T2 shine through because the lesion was not T2 hyperintense. And then there's a possible low ADC signal correlate to confirm true restriction. And despite the motion artifact degrading the arterial phase, we can make out subtle peripheral enhancement, but no central enhancement likely due to necrosis. For surgeons, the MRI is not just a diagnostic study, it is a map. Every lesion needs to be described, the metastasis relationship to the hepatic vasculature, whether a lesion is peripheral or buried deep in the parenchyma, or perhaps close to a bile duct. All of that feeds directly into the MDT discussion about whether metastases are resectable, and if so, by what approach. And is there a role for PET-CT? Well, at our centre, we usually ask for one when patients are being worked up for a resection or ablation because PET-CT uncovers otherwise occult extrahepatic disease, changing management. However, its routine use is debated, and guidelines in different centres will vary in their approach. In this case, there was only tracer uptake seen in the segment 5 liver metastases. There wasn't uptake at the site of the segment 7 metastasis, likely due to its small size, but the study did confirm that there was no extrahepatic metastatic disease. So in summary, the MRI is best for mapping the liver, whilst PET is used to look beyond the liver. And now we bring our findings to the MDT. So the primary tumour was resected during that emergency surgery. There is no extrahepatic disease. The background liver parenchyma is normal. There are 2 metastases, one in segment 8 and the other in segment 7, which is posterior to the right hepatic vein by about 6mm. And that last detail, the relationship to the hepatic vein, isn't just descriptive. As we'll see, it directly shapes the treatment decision. So what are we trying to achieve with any liver-directed therapy? Well, we want to treat all disease with clear margins. We want to leave enough liver behind to maintain synthetic function, and that liver left behind has adequate inflow, outflow, and biliary drainage. For years, the default assumption was that anatomical resection, so a formal right or left hepatectomy, was the gold standard. But the evidence has shifted. Multiple studies now show equivalent oncological outcomes between anatomical resection, for example a left hepatectomy displayed here, and parenchymal sparing surgery, sometimes referred to as non-anatomical resection or wedge resection. As a result, the parenchymal sparing approach shown on the right is now favoured wherever feasible. And anatomical resection is reserved for lesions involving major vascular or biliary structures where there is no safe alternative. The logic here is important. If local regional resection is oncologically equivalent to a major hepatectomy, why take more liver than you need? And this matters because hepatic recurrence after resection is common. Over half of patients will develop recurrence, and roughly half of those recurrences will be confined to the liver. And when that happens, having enough preserved parenchyma keeps rehepatectomy on the table. That same thinking, spare parenchyma, has driven growing interest in ablative techniques. And now there are no randomized control trials that directly compare non-anatomical resection with ablation, but accumulating data suggests comparable outcomes in carefully selected cases. And the working criteria most MDTs apply are lesion size under 3 centimeters, that the lesion is intraparenchymal and not subcapsular, as subcapsular lesions carry a higher risk of incomplete treatment and complications, and that there should be at least 4 to 5mm clearance from major hepatic vessels, as biliary, as the flow in the vessels can reduce the efficacy of the treatment, and this is called the heat sink effect. And so non-anatomical resection now has a role for lesions if they are larger than 3 centimeters or if they're in a subcapsular, very superficial location. And so for our patient, both lesions meet the criteria for ablation. And this is the post-procedure follow-up MRI where there are two large overlapping ablation zones with adjacent perfusion-related change, but no evidence of residual or recurrent disease. But what happens when disease is more extensive? Here we see an intraparenchymal metastasis measuring over 3 centimetres, close to major vascular structures, including the IVC. There are multiple additional metastases within the right lobe, whereas there are simple cysts in the left lobe, as well as a large peripheral lesion involving the middle hepatic vein. In this case, clearing all disease would require an extended right hepatectomy. But now we must think not only about how we remove disease, but whether enough liver would be left behind. Before any major hepatectomy, we need to measure the future liver remnant on CT using volumetric software. In a healthy liver, a remnant of around 30% is usually sufficient, but this rises to about 40% when the liver function is compromised by steatosis, chemotherapy, associated injury or cirrhosis. And some centres might use hepatobiliary scintigraphy for additional functional assessment. Now, if the predicted remnant is below the threshold, resection should not proceed, at least not yet. Now, the most established strategy for increasing the volume of the future liver is portal vein embolization. The principle is straightforward. By occluding the portal venous supply to the lobe that will be resected, we redirect portal flow to the future remnant liver, stimulating hepatocyte hypertrophy. Here we can also see that the right hepatic vein has been embolized to stimulate growth further. Over 4 to 6 weeks, the remnant lobe grows, and we monitor that growth using serial volumetric CT. And once adequate hypertrophy is confirmed, the diseased hemiliver can be resected. Now, beyond resection and ablation, the treatment landscape continues to expand. Transarterial radioembolization is already in use at specialised centres, whilst hepatic artery infusion chemotherapy has a renewed interest internationally but is not routinely used in the UK. However, I want to highlight 2 areas we are beginning to use at our own centre. Histotripsy is a non-invasive focal ultrasound technique, so no needles, no heat, no radiation. Ultrasound pulses generate cavitation bubbles that mechanically lyse tumour cells. It remains an emerging treatment. However, the hoped-for liver trial has been a key evaluation study, leading to FDA breakthrough device designation in the United States, but availability in the UK remains very limited. Whereas liver transplantation for colorectal liver metastases is perhaps the most striking shift in thinking. For decades, it was a complete contraindication, but the Oslo SECA trials challenged that, and the TransMet randomised control trial has reported significantly improved 5-year survival in the transplant arm. And in the UK, a national service evaluation, so the UK COMET study, is underway to assess transplantation for carefully selected patients, so those with a controlled primary, liver-only metastatic disease, and that those metastases are unresectable and show stability on systemic chemotherapy. Now, these criteria will not apply for most patients, but liver transplantation is no longer categorically off the table and offers hope for some patients. Finally, I want to come back to our patient. He is 37, and while that might feel like an unusual age for colorectal cancer, it is part of a striking and well-documented trend. Individuals born in the 1990s now face at least a 4-fold higher risk than those born in the 1960s. And by 2030, it is projected that 11% of colon cancers and 23% of rectal cancers will occur in the under 50s. The reasons behind this remain incompletely understood, but the message for radiologists is clear. Don't let age reassure you out of the right diagnosis. So in summary, we started with a man with a splenic flexure tumour and a single 9mm liver lesion that could have been anything. And by following his journey from that first CT through to MRI, the MDT discussions and treatment options, I hope what did feel like a series of technical decisions now feels like a coherent framework that you might be able to work from. And some things I hope you can hold on to are: firstly, the same hypoattenuating liver lesion means something completely different depending on who it's in. Risk stratify first and then decide whether further workup is warranted, because knowing when a lesion genuinely changes management is what separates useful reporting from noise. Secondly, match the imaging to the biology. Portal CT works for most, but don't forget hypervascular primaries or you'll miss metastases entirely sometimes. And lastly, ask yourself, am I trying to characterise a lesion or map all of the lesions? That question should determine which MRI you request. And remember, the radiologist needs to produce a report that can be the surgeon's map. Thank you for listening.
Hey everyone, I am pleased to be joined by Dr. Ed Godfrey and Dr. Katie Hickman, who are both abdominal radiologists working in Cambridge in the UK. And the three of us have a love of liver imaging in common. So, welcome to you both.
Hi, how you doing?
And I'm Dr. Matt Morgan from University of Pennsylvania. I'm going to be your host for this session. But I thought we might start with sort of a general overview. Let's say you're not super familiar with liver imaging in general here. Ed and Katie, can you tell me why liver MRI has become so essential to your practice? And what are the great things about liver MRI today?
Do we go first, Katie?
Oh, okay. Um, yes, you're right, Matt. Love liver MR, and it is a major focus with how we conduct our GI imaging in Cambridge. It will really vary, I know, from centre to centre as to how you choose to image certain things. But I think there are probably three main areas where liver MR really stands out and can do things that CT and, in my hands, contrast enhanced ultrasound can't do. So I think if you have a young people with normal background liver and an indeterminate lesion, that's where it's find it super helpful over all the other modalities. And then in liver metastasis imaging, when you're really trying to detect all of the lesions in the liver to help plan curative, sometimes curative surgery. And then finally with imaging the biliary tree, which is slightly outside of what we're going to talk about today.
Ed, anything to add?
Yeah, totally agree with all that. We use it a lot for our HCC practice as well, both in characterizing things when we found them on ultrasound, but also we've started using it as a surveillance tool as well for HCC. And then we increasingly using it to image diffuse liver disease as well. So we can use it to try and avoid doing so many liver biopsies. I do like a good liver biopsy, but if I can
You do.
avoid doing one, that's good too.
That's great. Well, I'm biased. I think MR of the liver is amazing. So why don't we just use it on everyone? What are some of the limitations of using MR in practice?
I think it's really difficult to do well. I think unlike
Okay.
CT, where you can get really reproducible images, liver MR really requires a lot of love and attention to get your sequences where you need them. So, for example, as Ed mentioned with our HCC work, I think you can use CT and MR in that instance, and really they're complementary, depending on how well a patient can tolerate an MR. If they're great at lying still, they can do the breath holds, and you've worked with your radiographers and your app specialists to get the images where you need them, then it's definitely superior. But sometimes a CT can step in if the images aren't quite where you need them. Ed, I don't know what you think.
Well, so yeah, with the newer scanners, we can get most patients through an MR scanner now, can't we? So we've got a wide bore magnet, so most patients will fit now. The real limitation we have is just MR resource. So as fast as we can install new magnets, there's demand filling them up. I'm sure we're going to talk about it a bit later, but some of the newer techniques we can use can speed up the imaging of these patients, which is a nice thing to have. It means more work for us, unfortunately, but it does mean that we can scan more patients with the existing MR footprint that we've got on site. So that does help. So we're using it increasingly.
Yeah, I always like the analogy that MR is amazing. It's like a finely tuned race car. It can do an amazing things, but it also breaks down a lot. It also needs a lot of love and attention in order to make it work correctly and in order to get everything out of it that you can. And so that's some of the difficulties we have with keeping MR useful in practice. So let's jump right into it. Let's talk about diffuse liver disease. I figured that'd be the first topic we could chat about here. And that is one of the strengths of MRI compared with our other imaging modalities. And there are some newer techniques that we can use today in order to better characterize diffuse liver disease. Um, so let's start with well, the first things I think of normally are fibrosis, hepatic steatosis, and iron deposition disease. So I just wanted to put that out there. That's kind of what I mean when I'm talking about diffuse liver disease. So let's start with hepatic steatosis. Um, how are you all imaging hepatic steatosis in your practice?
Yeah, great question. I just want to echo your comments about how important diffuse liver disease is, and it's the cornerstone. Even when you're looking at a focal liver lesion, you have to decide before you're looking at the focal lesion what the background liver is doing, so that you can get the right differential. So yeah, it's absolutely essential. So yeah, for steatosis, we have a specialized sequence which is proton density fat fraction. So the way it works is, I'm sure a lot of the listeners will be familiar with 2-point Dixon imaging, which we use a lot for just fat suppressed T1 weighted imaging, and that works by in and out of phase T1 weighted images, and then you can use those to calculate a fat only and a water only image. And the water only image is what we commonly use for a nice fat suppressed T1 image with nice uniform fat suppression. So you can extend that technique beyond just the 2 points to a multi-point Dixon technique, and most of the vendors versions of this use, say, 5 or 6 points. And the advantage of having more points in your Dixons is that it means you can model a curve, not a straight line. And so that means that you can model this nice wavy line that you get as the signal varies as it goes in and out of phase, but also decays over time. And the change in signal between the in and out of phase images gives you your fat measurement, but then the rate of decay over time gives you an iron measurement. And by measuring the curve, you're able to standardize your measurements based on so you can allow for the presence of iron when you're measuring fat, and vice versa. So it means that you're not trying to model a curve with a straight line, which can cause problems. So I'm sure we've all come across patients who've got both iron and fat in the liver, and it looks like neither is present because they're balancing each other out. So yeah, we use proton density fat fraction imaging to measure actually both the iron and the fat.
It's great. Yeah, I was you're actually anticipating what I was going to ask. Is, do you use PDFF, or proton density fat fraction, for imaging? That is definitely a newer technique. In the U.S., not all the centers, at least in my area here, are using that. They still sort of rely on the chemical shift imaging and just a percentage. But you're right, that PDFF can give you an absolute value of the amount of fat in the liver, which is kind of nice. Just basing it on percentages, which can be biased. So that's great.
I would just say it's a pretty easy thing to bring in. You've obviously got to pay the vendor to unlock it on your machine, but once you've got it going, it's just a single breath hold. And the really important thing to know is that the percentage you get from the PDFF isn't the same as the percentage that the pathologist will quote when they're reporting liver biopsies. So you have to cross-reference it with a table of values. But yep.
Have you done any work at your center into sort of seeing from whether the PDF is matching your liver biopsies or anything like that? Have you sort of normalized around that? Or
We sort of stopped using liver biopsies to assess steatosis, and I think that the general feeling from the literature is that PDFF is probably more accurate than biopsy, because the biopsying is really an eyeball estimate by the pathologist of what proportion the hepatocytes are involved, whereas PDFF is a sort of ground truth measurement. So yeah, we just use PDFF for research and for clinical cases.
no, that's an excellent point. And there's also there's a bias in you're only taking a small fraction of the liver when you're doing the liver biopsies, and when you're doing the PDF, you can look in the entire liver. Sorry, Katie, what were you saying?
No, I was going to say exactly what you just said, Matt. That
Oh,
it's
okay.
really nice
Sorry.
that you can see you can see the whole, you get the whole liver, don't you? And there can be real variation between lobes and segments as to where the fat is, and it's nice to see that on the PDFF.
Absolutely.
That's a great point.
So let's talk about fibrosis a little bit. And Katie, let's have you lead this off here. Elastography. So it's not exactly a brand new technique, but it's one that's sort of evolving over time, and it's taking hold more and more at different centers here. Do you use elastography? And if so, what kind of issues have come up?
So we do use MR elastography, and I'm gonna answer this with the help of Ed, because this has been a real labour of love of his to get this going. And what maybe I'll say where I find it most useful in how I report, and then Ed, do you want to tackle the implementation and sort of um, physics side of things? So how we're actually using a lot of MR elastography in Cambridge, and I think that's out of availability, and I know we're very lucky, because I don't think that reflects widespread practice in the UK, or that's my feel. It's really helpful because as we've mentioned already, a lot of these patients, where it's useful to know about the degree of fibrosis and cirrhosis, are having imaging for other things. So whether that be patients with HCC or suspected HCC. So if you're doing a Gadabus liver, you can add some elastography sequences on there, or indeed patients who have other liver disease such as PSC. That's another cohort of patients where when we're imaging the cholangiopathy, we can just tack on those elastography sequences and provide sort of a really whole assessment of the liver without the need to touch a needle. So that's why I really love it. Ed, I'll hand over to you to the.
Oh, thanks. Well, it's good. Yeah, I think we all find it really useful, don't we? So the reason we've got it in Cambridge is because David Lomas was, who was our professor of MRI for many years, was on the original paper with Dick Amon, who was the president of RSNA. So this was, I can't remember how long ago, but a while ago, front page of Science, the journal, and they were the first people to get elastography working with MR. And so we've been one of the early sites to use it, and so we've got quite an experience of it. But there are lots of other sites using it across, particularly North America. I think a few sites in the UK now, and it's an easy thing to set up. It's a bit more involved than starting PDFF in that it's not just a software upgrade. You do need some hardware. So you need to buy, there's a kit you can buy which consists of an active driver, which is like a sort of electric box that you plug into the wall, and it just blows air out at a regular frequency, usually 60 hertz. And that goes down a length of like garden hose tubing to something that looks a bit like a ping pong bat. And that's the passive driver, which you put next to the patient and causes vibrations from that air pneumatic pressure to transmit into the patient. And by setting up those vibrations inside the patient, you can use special MR sequences. They've got motion encoded gradients in them to measure the shear wave as it goes through the liver or other organs. And then based on how rapidly that shear wave travels, you can see that by measuring the distances between the peaks and troughs. You can infer how stiff the liver is. And the stiffness, generally speaking, correlates quite well with the level of fibrosis. So that's what we do when the hepatologists ask us if there is cirrhosis or fibrosis at earlier stages than cirrhosis. Then that's what we would use in a proportion of cases. We don't use it for everyone because, just like we were saying for liver MRI, it's more expensive than many other tests that we can use. So by and large, most patients will go to FibroScan, which is an ultrasound-based elastography technique, which the hepatologists do, which is great. So any test that someone else can do for us is a good test. But when that gives unclear results or no result at all, then we tend to use MR as our sort of problem-solving tool.
Have you noticed that the hepatologists send particular kinds of patients to you for your MR elastographies, or is it just kind
Yeah.
of a general group that you get?
No, it's a great question. As you might expect with ultrasound-based techniques, the FibroScan tends to fail in the larger patients with higher degrees of steatosis. So same as ARFI, acoustic radiation force impulse elastography, which we do use for a few cases as well. They tend to fail in those patients. So MR is really good in those patients. MR obviously has a sort of proportion of patients that it will fail for too. So there's the odd patient with claustrophobia, and it also doesn't work very well in patients with iron in their liver, and that's because most of the sequences are gradient echo. I think a few places have spin echo systems working, but generally they're gradient echo, and so they tend to fail in patients with any significant liver iron.
I was just curious too. With any sort of newer technique, there's a bit of a learning curve. Um, is everyone at all the body radiologists at your institution who read liver MR, are they reading the elastography, or are you kind of limiting it to a certain group?
Yeah, it's not all of us, is it? I think, Katie, what
No,
would you say
no,
about?
I think it's probably a third of us. Do you reckon are
Yeah,
doing third to half? Yeah.
yeah. Yeah, which I think it just, like anything, the more you do, the better you get at
Mhm.
it. But I'm sure it's something that any body radiologist could learn,
Mm.
and there are a few pitfalls, but it's a really nice string to have to your bow. There aren't many done on call, fortunately, so you can do them as cold cases.
Yeah, it's more by nature of how people's work has fallen rather than it being a particularly challenging skill to acquire, I think.
Gotcha. All right. Cool. Well, that's great discussion on diffuse liver disease. In the interest of time, we're going to keep it moving here. Let's talk about contrast agents, new things that are sort of brewing in contrast agents of liver MR. So let's start, Katie, with you. What contrast
hmm
agents are you currently using at your institution?
Yeah, so we, for liver imaging, we use two different contrast agents. So we either use extracellular contrast agents, so that would be Gadavist, or we use a hepatobiliary agent. So that in our case, that would be Primavist. I know some people call that Uvist, gadacetic acid. And we use I'd say we use the extracellular contrast agent for probably about 75% of our imaging. And where we're using that is in lesion characterization, whether that be, as I was talking about at the beginning, the indeterminate lesion in the otherwise normal liver, or the HCC. That's where we're all of our HCC imaging is with Gadavist in Cambridge. I know that will vary. Different centres I appreciate might use Primavist in that
So,
instance.
so tell me about that. Why do you guys like to use Gadavis as opposed to Eovist for HCC imaging?
Yes, so and I know that there is so where that stems from is from the LIRADS manual, and that we found so this is the LIRADS being a mechanism by which we can characterize lesions in a cirrhotic liver and give a probability-based score as to whether we think this is definitely HCC, probably HCC, or not. And the LIRADS manual we felt was easiest to apply using Gadavist, for two reasons. Firstly, because you have multiple shots at seeing the washouts. You've got the portal phase and the delayed phase imaging, whereas with Primavist, you've just got that portal phase opportunity to look for washout. And then the second reason, and I think this is the main reason where I prefer, or I like Gadavist for HCC, is that you don't get the the physiological respiratory sort of hyperventilation in the arterial phase. And if AFI is the cornerstone of the LIRADS manual, you really need a good arterial phase, and that's, I think, the main reason.
And AFI being the arterial
The
phase,
arterial phase
right? Or phase, right.
hyperenhancement, yeah.
Gotcha. Yeah, you get the, you're right.
Hmm.
Uvist, or gadoxetate, can
Yeah,
really mess that up. So that's, yeah, we do
yeah.
the same thing actually.
No, I think interesting times might be coming up in HCC imaging, which might be a bit beyond the scope of this, but I think they're going to suggest that everyone uses Primavist. But anyway, we'll cross that bridge when we come to it.
Well, no, this is the
Um,
time to talk about it.
uh,
We're talking about current, and we're talking about the future. So tell me what you see on the horizon.
well, there is, it's not yet been published, but there are proposed changes. There's been a long-awaited LIRADS update, and we've just been talking about that this week, that for multiple reasons, namely working out whether something's definitely a mass, I think, in the hepatobiliary phase, but for multiple other reasons. Um, yes, we'll see. It'll be interesting, very interesting times, because it's certainly been a doctrine at our centre that for HCC imaging, you use Gadavist, you use extracellular contrast agent. So yeah,
So is the
interesting.
idea to sort of cut down on the number of LR3s and little like,
To shift, they've done a lot of statistics work as well, which was all very impressive, based on which of the current major and ancillary features were working, and which weren't. And so bringing in that HPB phase hyperintensity might be a change as a sort of major feature.
and were you going to add something about that?
Yeah, I was going to say, as an enthusiast for difficult biopsies, I'm keen on more Primavist, because what's going to happen, I think, is that we'll end up with more LR3 and 4 observations that we need to biopsy, based on that. There'll probably be small nodules that are hypointense in the hepatobiliary phase. So
Right,
bring it
right.
on. That's great.
Yeah, I think you could fully argue it both ways, though, because you could, very easily misclassify a hepatic hemangioma using Primavist
Well,
for
that
your.
naturally leads into sort of my next point here. Have y'all ever attempted dual contrast agents, or using two contrast agents? Do you get the best of both worlds, or do you not get any world at all? Or have you even tried it?
Do you mean it's on the simultaneous
Yes, I'm sorry. Yes,
administration of both?
simultaneous. Exactly. Sorry, simultaneous contrast agent injection.
Yeah, we talked about it, and I can definitely see the attraction. I think anyone who does any sort of liver metastases MRI will have the odd case where they've unfortunately sent the surgeons in to resect a small hemangioma. I think it's very difficult. So we haven't done any simultaneous dual contrast MR, but we've done quite a lot of. Well, we're quite liberal with bringing patients back for giving the other sort of contrast, and I think we're always doing that with an eye on not resecting a hemangioma, is probably the commonest reason for doing that. Have you tried it, Matt? What's your experience?
No, we haven't, at least not to my knowledge here. Maybe sort of in a research setting probably, but not clinically. I think there is not a tremendous appetite to do it at the moment just, because of the risk of gadolinium deposition in the brain, and nobody's quite sure how much gadolinium we should really be pushing, it's just in the general population. Um, but if there's a convincing clinical benefit, then we may move toward it. I just don't think we've, found that quite yet.
Yeah. My worry is what happens in the middle there when you've got your transition phase
Right.
and delayed
It's
phase
like a mess.
and yeah.
Have you all had a chance to use, gadoxetate, Primavast, Eovist as a functional marker? I know there's some research out there is predicting risk in post-hepatectomy liver failure or anything like that. Have you had a chance to do any of that?
So it's not, correct me if I'm wrong, Ed, but it's not something that we routinely would do in Cambridge. I know that we do have patients who come in with liver failure for multiple reasons, and then you definitely do see that different signal intensity between the liver and the spleen, or the liver and the musculature, and you can really infer from that about the impaired. You can see how it would work to demonstrate impaired liver function. My understanding is that the liver function has to be significantly impaired before you start to see that sort of differential signal in the liver. And so we don't use it routinely for those patients who may be going for resection. Where the hepatobiliary agent is useful, I think, for those, say, patients with liver metastases who might have them resected, is to check that there aren't any features of chemotherapy-induced damage. So signs of sinusoidal obstruction syndrome. That's where I I quite like to use that agent.
Yeah, it definitely has some biliary applications too, but we weren't really going to get into too much of that, so I didn't want to push you on that. Sorry, Ed, what were you saying?
Oh, just sorry, I jumped in. I was just we for prediction of liver, small for size or liver failure after liver resection, we stick to just pure volumetry, and
Mhm.
I don't see us having lots of patients with small for size. So I think that seems to be working okay for us without adding in the functional aspect.
All right, well, let's keep moving here. Let's talk about protocol design. Let's get on the frontiers of protocol design here. So, before we even dive into the specifics here, what do you all think are some pressing needs in protocol design? I mean, how do we? What are some of the problems they were encountering, and like, how are we, responding to them?
Should we talk about our abbreviated liver MR,
Yeah,
Katie?
that's good.
Is
We
that,
sort of
shall I go
hinted
for
at
that?
that before, right?
Yeah.
Trying to speed things up so we can get more patients taken care of. So let's talk about abbreviated protocols.
So we should both pay homage to our glorious leader in body MRI, which is David Bowden, who is one of our beloved colleagues who's done a huge amount of work in optimizing all sorts of things in body MRI, but has also set up our abbreviated MR service for patients who have an increased risk of HCC and are not good candidates for ultrasound. So we use the LIRADS scoring system for visibility on ultrasound, and for those patients who are not well seen on ultrasound, so visibility score C, we direct those to MR now, and they have an abbreviated MR with hepatobiliary specific contrast medium, so Primavist, and we follow them up 6 monthly like that, and that's been a big change in our practice. We've talked about it for a long time, but Dave got it done, and so it's a very brief protocol. I'm going to try and remember it off the top of my head, but I think it's a T2, diffusion weighted, and they get given Primavist before they get on the table. So it's just a hepatobiliary phase T1 fat saturated sequence. So it's all done very, very quickly, and means that it's quite practical. And we are not struggling with the volume of patients that we're swapping from ultrasound to MR. It's worked really well.
It's more a sort of detection sequence, isn't it? And then if we need to bring them back, we'll bring them back for again a Gadabis, an extracellular contrast agent study.
Well, this is a little bit tangential, but I think it's relevant. So tell me a little bit. So you sort of hinted at it a little bit here, Ed, about what's the sort of screening framework in the UK for patients who are at risk for HCC. Part of the reason I ask that is in the US, we sort of know what we should be doing, but the implementation of it is very heterogeneous. And some people are getting this, some people are getting that. We know we should start with ultrasound and then move to MR, especially in the cases like you're talking about with visibility C. Do you find that there's pretty good adherence to sort of the generally recommended guidelines for HSC screening?
That's a great question. I think we're probably similar to North America in that respect, that things are quite variable from center to center. So, we have a national breast screening program and a national colorectal cancer screening program, but we don't have a national HCC surveillance program for patients who are at increased risk. So, in different centers, they might have different ethoses. So there are some places that don't believe in ultrasound surveillance and don't do it, but we
Mm-hmm.
we as the center do. We're lucky to have engaged hepatologists who drive the sort of organizational aspects of it. So patients get their 6 monthly ultrasound and 6 monthly alpha fetoprotein measurements, and so we keep a track of them like that. We used to be able to marry up the ultrasound slot with their clinic appointment, but the ultrasound service is so busy now that doesn't really happen. But we know ultrasound's not a great test, so that's why there are a cohort moving across to MR. But I think it's quite patchy in the UK in terms of engagement, and certainly it's probably even in our region, it's patients who are maybe not so well off find it more difficult to attend for their appointments, and because it's not a funded national program, there's no real support for getting people to and from hospital for their imaging.
Do you feel that it's just your sense? Do you feel that the better adherence to that sort of program is increasing or decreasing the amount of MR that you're doing, or is it just sort of neutral?
Oh, that's a good question. I think we when we first brought in the abbreviated MR, we thought this could explode and become completely unmanageable. And I'm really pleased to say it hasn't done. One of the things that we do is that before someone swaps from ultrasound to MR surveillance, we have a review by one of the body radiologists to make sure that they agree it genuinely is a poor liver to look at with ultrasound. So the sonographers, they'll all store a sweep through the right lobe to give a feel for how challenging the liver is. But we accept most of the ones that they send over. Occasionally, we'll then bring them back and get a consultant to scan the patient rather than a radiographer for the next scan and see if we can do any better. But there's some interesting evidence. So looking at patients who are difficult to scan with ultrasound, maybe because they have a more heterogeneous liver, there's evidence to show that those are the patients that you should be looking at more carefully. They're at an increased risk of cancer over the ones that are easier to image. So yeah, we think it's a good thing to do.
It's a really nice, I find, safety net to be able to have that abbreviated MR protocol, because when you're scanning a liver and just you can't get the ultrasound beam to get nicely to the back of it. And I think for those patients with ultrasound visibility score C, to have a way of just double checking that there's nothing there is so helpful.
Now, you outlined a little bit of some of the sequences in the abbreviated protocol. How long does it take overall?
Yeah, it's very quick. I think it's under 15 minutes.
Under 15 minutes. Okay,
Yeah, it's super quick.
cool. So tell me a little bit. Are you, Katie? Do you guys use subtraction imaging at your institution, or do you prefer that over the, alternative?
So yes, so subtraction imaging, so where you've got your post contrast imaging, and then you take away your pre contrast imaging to make sure that the enhancement that you're seeing is real rather than T1 hyperintensity that might be there. So we have subtraction sequences in all of our liver MR, and but I appreciate that there's a very wide range of practices as to how people can use it. Um, we mainly do that, I believe, because we don't have supervised MR lists. So to try and prevent having to recall patients when those lesions are T1 bright. But I guess a really good alternative is if you see something, if you have a liver lesion and it has got T1 hyperintensity, that you could just add the subtraction sequences at that point. I think that would be the main time I'm looking at those sequences rather than just relying on the standard sort of dynamic contrast phases.
Are you able to sort of change the protocol as it's moving along? I mean, are you able to add subtraction sequences as the patient's being scanned, or is it something you sort of
We
generate
have,
later?
yeah, we have, so we have fixed liver MR protocols, and all of
Okay.
them, um, the um, the radiographers will always send subtraction sequences
Okay.
for everyone. Yeah.
Yeah, I've noticed that some of it. Yeah, some of the attendees at our institution, some love the subtractions, some don't like them so much, they don't trust them. So I'm always curious to hear, how people at different places like use them.
What's your feel, Matt?
Well, it sort of depends. So we also, when we get subtraction images, it sort of depends on which scanner they were scanned on. Like some of them generate them automatically and some of them don't. So it's not like we get a ton of practice. Um, But it sort of depends. Some of them may be pretty messy and I just have to throw them out, and some of them are quite beautiful, in which case they're very useful, especially for renal lesions, but that's not really what we're discussing today. So,
Okay, nice. Very
yeah.
cool.
So I'm a fan, but it doesn't always look pretty.
So something we get reminded about by one of our colleagues on a regular basis is that you can't use subtraction images for LIRADs,
Yeah.
the sort of an official way. So I'm always trying to remember that. But I think when they work, they're absolutely brilliant, aren't they?
Yeah. Well, one of the problems with the detraction images is respiratory motion, right? I mean, that's a problem with any sort of imaging of the abdomen here. Are you all using any particular sequences in order to minimize respiratory motion in the abdomen?
Yeah, yeah. So we've got a few nice sequences on our scanners. So we've got G scanners, and there's a sequence called Lava Star, which we use routinely in our livers in the delayed phase or hepatobiliary phase, which is just a free breathing sequence. You got time in that context to get a free breathing acquisition, and they generally give very robust, lovely images, even in patients who can't respond to breathing instructions. So if there's a language barrier, it doesn't matter. Obviously, it's not so useful for the arterial phase, so we've got other techniques for that. So like a lava disco, which we can use, which gives slightly noisier images, but is still pretty robust in a free breathing situation. Are you using similar things at your place, Matt?
Yeah, yeah. We have a lot of Siemens equipment, so we have used sort of the corresponding sequences, but yeah, respiratory motion is always an issue.
Challenge, yeah. But I guess there's lots you can do before applying these fancy sequences, which sometimes we skip past. So,
Very true.
making sure
Yeah.
if you're going to scan the acute patient that their large pleural effusion has been drained beforehand,
Hmm.
or just even counselling the patient beforehand as what to expect, or if you've got a interpreter nearby. Um, I think there's so much that we can do ourselves to optimize liver MR as well as the help of these new sequences and the bits that are on the horizon with the sort of deep learning reconstruction.
Well, yeah, actually, two things that feeds in well to like the idea of the abbreviated protocols. If we can keep the protocols shorter, maybe patients don't have to hold their breath as longer, and so that's definitely going to help with that. And sort of moving into the next topic here, sort of looking at future, you know, applications to liver MR. Are you guys using AI? Got to ask these days. Any sort of AI applications in your protocol design?
Um, so so yeah, we're super lucky with GE and the technology that we have in that there is a sort of AI enhanced aspect to how these images are being acquired, and I think that's the deep learning reconstruction that I alluded to there. My again, Ed, you can fill in the physics gaps here that I overlook, but my understanding from a very basic perspective is that it enables us to scan faster and also to reduce artifacts by sort of limiting the areas it samples and then guessing what's in between, and the images that we get are lovely and acquired quite quickly, even though we have quite long protocols.
Absolutely. We're not using it for reporting yet, but I don't know
No.
for how long.
I'm
how,
going to
how
hold
about
out.
how about you, Matt? Have you got lots of AI going on?
Well, not in the liver so much, is my understanding.
Okay.
So we are using it in prostate, and we're sort of slowly rolling it out, trying to make sure that we are not rolling out too quickly. That's not generating hallucinations. So there's a lot of um, duplication of sequences. We compare the AI, which is much faster. That's why we can sort of duplicate it because it's generated so quickly that you can just sort of tag it on. And once we feel really comfortable that it's, not hallucinating things, at least in the prostate, then we'll maybe move a little more toward it. We have not attempted, is my understanding, we have not attempted it with the liver yet. But it's probably coming. It's probably coming.
It's pretty nuts. So for T2s, it's been a game changer for us. We do everything in
Mm.
a single breath hold, whereas we always used to have a quite a lengthy respiratory gated T2 sequence, and our T1s are usually, they're isotropic often now in terms of the pixel size. So you can get really, really good resolution on these images without increasing the time of the scan.
Great. So let's chat real quickly, sort of wrapping things up here. Let's talk about sort of an exotic application of contrast agents. That's something that's kind of maybe on the horizon. That's peptide or antibody tagging with gadolinium. Um, have you all had a chance to use any of this? Is there any research going on that you're aware of in the UK and something like this?
So Katie's already nominated me to answer this question,
I'm
which
so
I feel is
sorry.
very unfair.
I've thrown
'Cause
you under the
literally
bus.
the first thing I've ever heard about it. But I'm going to change the subject to something similar that I do know
Okay,
about.
please.
So
Yeah.
we we have an interest in hyperpolarized carbon imaging in Cambridge. So our professor of radiology, Ferdia Gallagher, has been working on this for years. So this is pretty science fiction. So what they do is they take a compound which is labeled with carbon-13, for example. They cool it down to nearly absolute zero. Then they warm it up and then they inject it into a patient. And the signal you get back from the carbon-13 atoms is many orders of magnitude higher for a brief period of minutes. So it means that you can label compounds that would otherwise be quite difficult and image them with MRI and image things like pH in vivo, which is really cool. So we've all watched his talk on what he's doing gradually evolves over each time he gives it, and now he's imaging patients. It's probably going to have quite useful role in oncologic imaging, and is similar in terms of what you can do with it to PET, but obviously without the radiation. So I think that's definitely something that is moving from the sci-fi realm to clinical practice in the near future. What do you think about gadolinium labeled peptides, Matt?
Oh, well, yeah. No, it's purely a research thing as far as I'm aware of in certain centers in North America. That's why I was kind of curious if it was being played around with in other countries as well. It's certainly not in clinical practice. But just to wrap up here, just let's take a moment here. Katie, what do you think are the sort of the key takeaways of the current state of liver imaging here? What still needs to be addressed and what are we doing right?
Oh gosh, so I think lots is going well, and as I said, it feels like it's a huge part of my practice as a GI radiologist reporting MR and especially liver MR. Um, I think it has many advantages over other modalities, but is not the be all and end all. So if you don't have easy access to liver MR, then you can do a lot of these things with good CT and good ultrasound. Um, where we are, what could be sort of where we could work on things. I think keeping it simple as well. So as I said, just making sure that the images that we do produce are of good quality. So we've all mentioned about respiratory motion artifact, and we can there are ranging from there are so many things we can do to improve that. So whether it's just talking to the patient beforehand, getting them used to being in the scanner, having a really compassionate, great radiographer to coach them through the scan, all the way up to the other end of these new fancy sequences and even AI enhanced fancy sequences. But definitely the quality of imaging that we're producing is improving, and that's really exciting. Yeah. What do you reckon, Ed?
Well, what I love about MR is that it's a combination of this sort of science fiction technology and the best joke I heard about it was when you were trying to explain how MRI works to orthopedic surgeons, you just tell them it's magic. But it's that, and it's very mysterious. But then that combined with the very sort of really important human aspects of it too. So I think we'd all want to acknowledge the amazing work that the MR radiographers we work with do, the MR physicists and the application specialists. The reason that we are able to look at these amazing images is because of the hard work and insights of lots of different people that we're lucky enough to work with. So I think it's really nice that combination of science and human input.
Excellent. Awesome. Well, thank you both for this deep dive into liver MRI, and it's exciting to think about where we're going to go over the next few years. So don't head anywhere yet, because except it's Michael now, the review of liver segment anatomy.
Hello everybody and welcome to this talk looking at liver segmental anatomy. Today I'm going to show you how we can divide the liver into 8 different segments using the Queneau classification. Each one of these segments has its own dual vascular inflow, its own biliary drainage and own venous drainage, and as a result it can function as an independent unit. The liver is different from other organs like the brain or the heart. You can't remove the frontal lobe and the brain functions normally. You can't remove the left ventricle and the heart functions normally. The liver is fairly unique in the way that you can remove a segment or leave behind a section or a segment, and for the most part, it can continue functioning normally. So how do we go about dividing the liver? We're not now using the falciform ligament and saying there's a right lobe and a left lobe. We're going to go into a little bit more depth here, and I'm going to show you the 8 different segments, how to look at them first on a diagram, and then we're going to look at a CT scan. So the first important piece of anatomy, remember the liver is a right-sided structure. Behind it is going to be the inferior vena cava running posteriorly. That's really important to identify the inferior vena cava and the hepatic veins that drain into the inferior vena cava, because it's the hepatic veins that are going to separate the liver into what we call sections. These sections can then be further subdivided into segments, but first we divide them into sections. The right hepatic vein, the middle hepatic vein, and the left hepatic vein separate the liver into 4 different sections, which we call the liver sections. Remember, the right-hand side of the liver here wraps round posteriorly. So we've got an anterior section and a posterior section. On the left-hand side, in the coronal plane, these 2 sections are in line with one another. Wraps round from anterior to posterior here. This first division that we've made with the middle hepatic vein is what's known as Cantley's line. That line runs from the inferior vena cava to the middle of the gallbladder fossa. That separates the liver into a left hemiliver and a right hemiliver. So we can divide the liver now into left and right. Those hemilivers, that's a primary division of the liver, can then be separated into sections. The first section on the right-hand side, I said, is most posterior. That's what's known as the right lateral section. It's the most lateral part of the liver on the right-hand side, or we can call it the right posterior section. That's divided from the right medial or right anterior section by the right hepatic vein. So you can see it's really important to identify the hepatic veins to divide the liver into sections. We then have the left medial section and the left lateral section. So 4 sections of the liver here. So the hepatic veins divide the liver into sections. We can further subdivide those sections into segments. So we have a primary division into hemilivers, secondary division into sections. We can then have a third or a tertiary division of the liver, which is going to divide the liver sections into liver segments. And it's the portal vein that we use to make this division. Where the portal vein bifurcates provides us with an axial level here known as the portal plane. That's going to divide the sections into segments. So you can see now that portal plane provides us with the liver segments, and these are what we're going to label here today. The first liver segment is what's known as the caudate lobe, and it's fairly unique from the other sections. The other sections are defined by the vasculature, by the hepatic veins, and by the portal vein coming into the liver here. The caudate lobe has its own boundaries. Posteriorly, it's the inferior vena cava. Anteriorly, we've got the ligamentum venosum, and inferiorly, we have the porta hepatis. Remember, this portal vein is coming into the porta hepatis. It's where the portal vein, the common hepatic duct, and the hepatic artery proper enter the liver here. So this will be the porta hepatis here. And when we look at a scan, you'll notice how these segments actually kind of wrap around the porta hepatis, and we can think of each segment as a cone-shaped segment heading towards the porta hepatis. So we've got the caudate lobe here. The caudate lobe on its inferior surface can be subdivided into 2 separate portions. Laterally, this side is lateral. Remember, this is the right-hand side of the liver, and the liver sits on the right-hand side. We've still got the stomach and the spleen on this side, the aorta coming out posteriorly. This is called the lateral caudate process. It's almost continuous with the right hemiliver. And on this side, the left-hand side, we can have a medial papillary process, which can be enlarged. I'm going to show you a example of that later on in a scan. So that's the caudate lobe. The caudate lobe can drain, its venous drainage can go directly or does go directly into the inferior vena cava. And that's why in some disease processes like cirrhosis or Budd-Chiari or primary sclerosing cholangitis, the caudate lobe can hypertrophy or stay the same size while the rest of the liver atrophies or gets smaller. And we can do something that's known as a caudate to right lobe ratio, where we get the caudate being large relative to the rest of the liver, and that's particularly prominent in cirrhosis. Okay, the rest of the segments I'm just going to name, not go into as much detail as the caudate lobe, because the caudate lobe is fairly unique, and I'm going to show you how these segments are named. The first is segment 2. I want you to think of naming the segments as a clock face. We're looking at a clock face and we're going around like this. We go clockwise, naming the different segments. So segment 2 is obviously above the portal plane, and it's on the left-hand side of the left hepatic vein. This division here is not always perfectly aligned with the falciform ligament. It often is, but we use the hepatic vein as the division, not the falciform ligament, because they're not always perfectly aligned. Below that then is segment 3. It's an inferior segment below the portal plane. And then the last lobe of the left hemiliver is segment 4. Notice how segment 4 isn't divided strictly by the portal plane, because these segments, by definition, are functional units. And the only half of segment 4 wouldn't be a functional unit on its own. That's why 4 can be separated into a 4A and a 4B. Think of 4 above and 4 below. But technically it is one individual segment, one functional unit here. Again, this line here is the portal plane that separates 4A and 4B. If you're describing where a lesion is in your report, it'd be much better to say 4A, then they know it's a superior mass, say, in the liver. So that's the left hemiliver. The right hemiliver, we continue the naming process in this clock face direction. So we're going to have segment 5 appearing here. Segment 5 is an inferior and medial segment. It's in the right medial section of the liver. We've got segment 6 then being divided from segment 5 by the right hepatic vein. Segment 7 being a superior and posterior structure, and segment 8 rounding off the 8 segments of the liver. So notice how we're labeling them here. Now, you can go through this, remember it, and then just forget it later on unless you're reporting lots, which hopefully you are. But another way I like to remember these right-hand side sections and segments is that the sections add up to 13. So you're unlucky if you don't remember unlucky 13. The sections add up to 13. And also, if you're unsure as to whether to label from superior to inferior or inferior to superior, know that the higher numbers sit above the portal plane and the lower numbers sit below the portal plane. Those are useful memory aids. So let's go and have a look at these on a scan. We're going to start with a portal venous phase CT scan here. Now, I said the most important structures to remember are the hepatic veins and the portal vein, obviously, because that helps us divide the liver into the different segments. So we want to find the inferior vena cava because we know that the hepatic veins are going to drain into the inferior vena cava. Here's the inferior vena cava, and a useful way to know it's the inferior vena cava is obviously it's a right-sided structure, a large vessel, but we've got the renal veins heading into the inferior vena cava. As we scroll up superiorly, we should see the hepatic veins go into that inferior vena cava. That's going to separate the different sections of the liver here. So we've got the left lateral section, the left medial section, the right anterior or right medial section. You can see why it's called anterior, and the right posterior or right lateral section here. So those are our sections. Then we want to find the portal vein because that's going to give us the portal plane. So we could scroll inferiorly and see the portal vein here. We know that the portal vein is made up of the splenic vein. Here's the splenic vein here. Follow that splenic vein. And the superior mesenteric vein. So this superior mesenteric vein is going to join the splenic vein and become the portal vein. Where that portal vein bifurcates into a right portal and left portal vein, this axial slice is the portal plane. So we know that above the porta hepatis here's the porta hepatis. See what I'm talking about by these cone-shaped segments directing themselves towards the porta hepatis. We know that above this, we're going to see the caudate lobe. Let me scroll superiorly. Here is the caudate lobe because its inferior boundary is the porta hepatis, the ligamentum venosum anteriorly, and the inferior vena cava posteriorly. We can see, if we look closely here, venous drainage directly into the inferior vena cava. I said that medially you can have this medial papillary process, and laterally we have the right caudate process that is almost continuous with the right hemiliver. So there's the caudate lobe. Let me show you an example of a prominent medial papillary process. So you can see here, a medial papillary process, if it's large, can look separate from the liver. This is the medial papillary process here coming out towards the stomach. And you could mistake this, say, for a mass or a large lymph node. It's important to follow it. You see it's continuous with the caudate lobe here. So this is a medial papillary process. You can see it on the coronal view here, heading out towards the stomach. Here is the lateral caudate process that's continuous with the right hemiliver. Okay, let's go back to our axial slices. We've identified the caudate lobe, we've identified the hepatic veins and the portal plane where the portal vein divides. We know that above the portal plane we're going to get segment 2 here, and next to segment 2 we're going to get segment 4A that lies between the left hepatic vein and the middle hepatic vein here. That's segment 4A because we're above the portal plane. Then we've got the anterior superior segment here, which is segment 8. You can see it labeled here. Segment 8 is anterior. It's medial to segment 7. Posterior to that is segment 7 then here, lying behind the right hepatic vein there. Let's go down until we see the level of the portal plane, where the portal vein divides into a right and left portal vein. Below that then is going to be segment 6 of the liver. Medial to that is going to be segment 5. See how they're pointing towards the porta hepatis. We will have, let's get our planes right again. I'm going to go superiorly. This segment here below the level of the portal plane, that's going to be segment 4A. And lateral to that on the left-hand side is going to be segment 3. So those are our segments there. See how the falciform ligament here doesn't always perfectly align with the left hepatic vein. Now, not only can you see this on a CT scan, you can also identify these structures on an ultrasound. And I'm going to show you some of the superior segments here. So we're in the axial or transverse plane of the liver here. We can see the inferior vena cava, the left, the middle, and the right hepatic veins that are separating the second segment from 4A, from 8, and from 7. And if you can identify the portal veins splitting and you can identify these hepatic veins, then you'll be able to know what segment you're looking at with the ultrasound probe as well. Below this, I'm going to leave this case here on Radiopaedia that has color-coded the different segments of the liver. You can see the hepatic veins, as well as if we scroll inferiorly, we can see the portal vein here that bifurcates, providing the portal plane. Look how those segments change color as we go above and below the portal plane. So I think I'm going to leave it there. Hopefully you get a better understanding for how to label the different segments. I'll see you all in other anatomy talks. Until then, goodbye everybody.
Fantastic. Thank you, Michael. And once again, thanks to Ed and Katie for their lectures and the wonderful panel discussion. It's now the end of this session, so I will bid you farewell. The next session here on the live page will be one with abdominal case workshop and also the abdominal R posters. So make sure you come back for that. I'll see you all again soon. Bye.